Let me just start out. My name is Laurie Tosharsky. I'm the director of the Global Educator Center for Excellence at the International Center for Missing and Exploited Children. This idea for this webinar came from some of our regional trainers, several of them in Middle East and in Africa, who came to us and said, you know, there's really not enough out there to support our healthcare professionals that are working in and with schools. And what can we do to support them? And so this webinar series was born, supporting school response and child protection for healthcare professionals and response team members. And we looped in ECIS, who we love working with in Europe, and they told us and the Office of Overseas Schools that we should throw the net as wide as we could. So we included every region. I think I have a slide here showing a little more information about the series. So we invited every region of the world, regional association, to broadcast this information to their members, and boy, were we successful. There are hundreds of people who wanted to join today. We will be posting a recording of this on the ICMEC site, as well as on all your regional association sites that are interested in doing so. And we have another webinar coming next Monday, and we added one on November 9th as well. The two webinars that are coming will be for healthcare professionals and the whole response team, child protection response team. They will be very participatory, so we have a cap on those, and they are both full at this time. So we look forward to joining some of you who are on this call. And I believe ECIS at least is doing an interest survey, and so you will be able to register your interest, and we will be doing more of these events. But at this point, I just want to say thank you to all of our partners and collaborators, and especially to the Office of Overseas Schools at the U.S. Department of State for their support of the Global Educator Center for Excellence. And now I'm just going to introduce Dr. Jordan Greenbaum, who is a child abuse physician who works with the International Center for Missing and Exploited Children quite as her most of the time, split with that and the hospital work that she does. So Jordan, if you'll take this from me and share your experience and expertise with us today. Thank you.
Thanks so much, Laurie, and thanks everyone for being here. I am really excited that there's interest. I'm a healthcare professional myself, and so I really think there's a role for healthcare professionals in identifying and responding to abuse and neglect when noticed in the school system. So I'm going to put up my slides right now, and we can get started. So. In the next 45 minutes or so, we're going to talk about the role of school health personnel in child protection. I think that, as I mentioned, I think that there is a pivotal role that we can play, and so we're going to talk about the various things that can be done. I'm hoping at the end of this 45 minutes, you'll be able to describe the role of the health practitioner in child protection and recognize potential indicators of physical abuse, have a better idea of how to respond to suspicions of sexual violence, and recall tips for providing trauma-informed care. All of these topics, there's a lot more to them, and I'm very glad to, do more, give more information at another time, and certainly answer questions, because I don't want you to feel like this is the only opportunity. When we think about healthcare personnel at schools, at international schools, we think, okay, what is their role? And I think they have multiple roles. They're first responders, for one thing. If you think about it, people are, students are highly likely to confide in healthcare professionals due to the specific role that we have, which are trusted authority figures who are expected to ask sensitive questions of patients, and the patients feel like they can trust. And so it may be that you get disclosures about abuse and concerns of sexual assault that perhaps would not be disclosed to others. The healthcare professional is also a child advocate. I think we have a really important role in sort of acting as the liaison between the child and authorities, especially when those authorities are the local community hospital, for example, if the child has to have a forensic medical evaluation. We can explain, we can provide support, we can run interference if there is difficulty with perhaps insensitivity at the community hospital. We can help with that and sort of help protect the child. And we're a collector of information and evidence. We ask questions, we gain information from the child and from our examination. So we have the opportunity to do a lot of things that can help with the child response team in schools. And I think we add something unique. We are the health perspective, the medical perspective that is very much needed in the child protection team. People need to know the impact on a child's health. So developmentally, what developmental concerns come in that might influence the child's disclosure or their health or the impact on their health. And as I mentioned before, we have a unique relationship with students that may allow them to confide in us and ask questions and allow us to give anticipatory guidance and helpful information that can either prevent abuse or diminish the adverse impact of it. Let's first talk about physical abuse, because I've talked a lot with personnel from international schools, and they say that physical abuse is a big problem. So there's corporal punishment, and then it's taken to an extreme for physical abuse. And so let's talk about the health professional's role in identifying that. You may be aware of risk factors for physical abuse just as you get to know your students. And there are some risk factors that at the child level, children with disabilities are known to be at higher risk for abuse of all kinds, including physical abuse. And this is especially true with children who have intellectual disabilities or disabilities that affect their behavior or their communication. And so they are at increased risk, and we need to be aware of that. There's some evidence that adopted or stepchildren are at increased risk in some studies, primarily out of the U.S. And then there are factors within the home and familial relationships that are associated with physical abuse. Unrelated adults in the home, for example, mother's boyfriend. This has been seen in some U.S.-based studies. Caregivers who use drugs or have mental health issues that are untreated. Intimate partner violence is a very important risk factor. Social isolation that you might see with your parents and families in the international school setting. And then cultural beliefs that endorse corporal punishment. And I don't want to imply that everybody who believes in corporal punishment is going to physically abuse their child, but I do think that there is a significant risk of engaging in corporal punishment, becoming very angry and losing control, and then it escalating significantly, especially if the child is being struck with something other than the parent's hand. That can easily get out of control. These are some of the potential indicators of physical abuse that you may notice when you're doing your examination of a child, for example, or as you're talking to a child. Things to think about as well. If a child comes to you and has an injury, you may be thinking in your mind that it's more suspicious for abuse if the explanation for the injury changes over time. The child sort of adds information, changes their explanation of what happened, or if their explanation doesn't match the injury, either in its mechanism or in the degree of force. For example, there's a tremendous amount of bruising and swelling, and yet the child reports a simple bump, very low velocity bump against a surface, which you wouldn't think would cause so much injury. So the injury doesn't match the explanation of it. Or the injury is not consistent with the child's developmental level, and this is more applicable to the very young kids who are gaining motor skills. Once you get to school age, and stuff, kids are running around doing a lot of things, so they can their developmental level isn't as much of an issue with injuries, but that is something to keep in mind. And then just noticing things about the injuries themselves, if they're located in protected areas of the body, if they have a patterned appearance, and we'll see examples of this. If you see multiple injuries, all blamed on one event, especially if they're on multiple planes, the front and the back, the right and the left, parts of the body, unless there's some clearly feasible mechanism that would expose multiple planes of the body to trauma, that should raise concerns. So let's take a look at what we call patterned injuries. And these are injuries that partially replicate the shape of the object used to inflict the injury. And you can probably guess, looking at the top left-hand picture of the child's face, that this is a handprint, and you see parallel lines of bruising separated by areas of spared skin. And so the area of impact is actually the spared area, and the bruising occurs at the edges of the site of impact because that's where there's maximal disruption of the blood vessels. So you get this outline of fingers, and this is a particularly well delineated handprint. In some cases, you only see 2 or 3, 4 lines, partial lines, without a lot of other evidence. So it may be more or less complete. In the top right-hand corner, you can actually see the bruising from a belt. You can even see the stitching on the belt. When a child is hit with an object at very high velocity, it slaps the skin essentially, and because it's high velocity, it tends to be sort of a superficial injury, and you can get, since it's very close to the surface of the skin, you can get fine detail of the surface that struck the child. So that's how you get this incredible detail of the belt. And in the bottom center, again, you see much like the fingerprint. This is a injury from a broomstick. And again, the site of impact is the spared area. The maximal disruption of the skin and the blood vessels occurs at the edge of the impact area, so you get an outline of bruising. If you see any patterned injury like this, it's almost always going to represent an inflicted injury rather than an accidental one. It's really hard to fall against something and get an accidental pattern injury unless, for example, you're in a car accident and you get an imprint of your shirt or something on the chest. As a bruise. But in general, pattern injuries are typically related to inflicted trauma. If you think about it, it probably makes clear sense to you. Most accidental bruises that are seen on children and adults tend to occur on bony prominences, and that makes a lot of sense because the skin over the bone has nowhere, there's no cushion there between the impact surface and the underlying bone, so the skin gets kind of sandwiched between 2 hard objects in bruises. And because people tend to move forward and look in the direction of what's happening, they tend to bruise themselves on the front of the body. Now, an active child can certainly and frequently does injure the back part of their bodies. That certainly happens, especially over the spine. As children fall, they get sort of a central midline bruising over the spine. But in general, things tend to happen to the front of the body. So forehead, chin, for example, knees and shins are very common areas of accidental trauma. And we don't usually take even notice of them if the child is able to run around and trip and fall and those kinds of things. But you don't tend to see accidental bruises in areas that are generally protected from accidental trauma, such as the ear. If you think about it, the shape of your head is such that when you fall, you tend to hit the area of the hat brim area of your head, so not the ear. The ear is sort of further down. And it certainly can happen accidentally. If you happen to fall on some object that's poking up and you land on it with your ear, you could certainly injure your ear, but it's relatively uncommon. On the other hand, it's not at all uncommon for this to be a site of inflicted injury. If a parent pinches an ear or boxes an ear, then there can be ear bruising. So when you see ear bruising, it's always helpful to ask more questions about what might have happened. And the same for the neck area is generally highly protected. You might see scratch marks from itching and scratching, but you don't tend to see bruising of the neck or anywhere on the torso in general. Again, the midline of the back is an exception, but in general, the torso is generally very protected, as are the inner thighs, the genitals. So when you see bruising on these areas, ask a few questions because there may be more to it than what we're thinking. And I don't mean to imply that any bruising to the shins is necessarily accidental when people are beaten, for example. They can be kicked and beaten on the shins as well. But it's much harder to say with certainty that a shin bruise is related to physical abuse, because it's so common to see accidental bruising there. One thing that is really important to keep in mind is the common myth, and that when I testify in court about physical abuse cases, we almost always have to go over this, is that it's almost impossible for us to reliably estimate how old an injury is. We tend to think, well, we can look at the bruise color, because the color changes over time. And yes, it does change over time. And when I was in medical school during the Stone Age, our textbooks all said that you should estimate the bruise age by looking at the color. But now we know that that's not reliable, that bruising can really be variable between people and within on the same person. The color and the appearance of the color and the resolution all depend on the health of the individual, the force used to cause the bruise, the depth of the bruise, various healing patterns, the location of the bruise on the body. So if you say, well, this bruise is yellow, we cannot assume that that is an old bruise. Bruising, yellow discoloration can appear as soon as 18 hours after after trauma. So it really, we do not rely on color or even swelling and tenderness to tell us how old a bruise is. So when anyone says, are these bruises different ages? Be very, very careful, because we really don't have a lot of evidence to support it if we say, oh, yes, they are. So what do you do when you see a bruise on a child, or you're concerned about abuse? How do you go about doing this as a health professional? You're sitting maybe in the examination room or your office with a child. You can just build rapport, and then say, can you tell me how you got this injury on your arm? Just tell me about it. What do you remember about it? That's a very open-ended question. And even a very young child, a 4-year or 5-year-old, can give you an answer to an open-ended question. They may not give you very much detail, but you can then ask, so tell me a little bit more, which is prompting them with another open-ended question. And you're going to have to fill in details about who, what, and when, because the child's probably not going to know to tell you that. So you might want to say, okay, you mentioned that you ran into a door. Can you say, where was the door? So you're sort of directly saying, directing them about where. But then generally want to elicit the explanation from them in a very non-threatening way, getting the basic information about who might have been involved, what exactly happened, and to a certain extent when is important as well. If you feel comfortable asking whether there was anyone else that saw what happened, that would be a good thing to know as well. And then also, did you see a doctor or a nurse for this? Because in many cases, you may be seeing a child who's been pretty severely beaten, and it's important to know whether the child was taken to a doctor or nurse for treatment. So those are some of the things that you can just ask, relying on open-ended questions. You basically want to get a basic history of what their explanation is for that injury. And you can do it in a very non-threatening way. For example, you're doing your examination, maybe you're listening to their heart and you notice a bruise. And so you just say, as you're listening, you know, say, oh, well, I see you got a bruise on your leg there. Can you tell me, do you remember what happened? That kind of thing. It's very non-threatening. It's sort of part of the evaluation exam process, and is the child is much less anxious about it. Some tips for talking with kids of any age is we have to remember to keep all of our questions about either physical or sexual abuse very non-judgmental, very calm, very accepting. Any answer they give us is going to be acceptable, so we're very non-judgmental. We build rapport before asking about things that are sensitive. So you may or may not know the student very well, but you want to, ask them about how their day's going, what they did last weekend, that kind of thing, to sort of build some rapport before asking sensitive questions. For the younger children who are very, very concrete, if you get a strange answer to your question, think about how you ask the question and whether it's possible that you are asking it in an abstract way and they are interpreting it in a very concrete way. And it may be also that children don't understand certain concepts at their age, so they may give you a strange answer because they're trying to guess what you mean. We want to rely as much as possible on open-ended questions that just ask for free narrative. Tell me more about that cut. What happened then, that kind of thing. And when we have to be direct to get more information, keep it simple. If you're going to ask about who, then ask about who, but don't also ask about who and where at the same time. And then always being sensitive to signs of distress that the child may feel uncomfortable, nonverbal language, or words that they choose when they're answering your questions are good ways to sort of monitor the amount of distress that the child may be feeling. We don't want to re-traumatize them with our questions any more than is absolutely necessary. Well, what do you do if you see some injuries and you're concerned about them? Well, in general, schools are not, in general, supportive of taking photographs by healthcare personnel, but you can consider diagrams, and these can even be fairly primitive diagrams. You can sort of sketch a body and put a little numbers or X's where these injuries are, and then you write a description of the injuries. And they don't have to be full sentences, but in your notes you can say, on the left, let's take this picture here, over the upper and mid back, that's the location, there are bruises. That's the type of injury. They are red, they are linear, meaning they form lines, and curvilinear, meaning they form curves. And are clustered in various orientations and cover an approximately X by X inch area of the back. That's it. You don't have to talk about every single injury there on that back. That would take you forever, but you can just sort of describe so that later on you can go back and say, yes, I can picture what that looked like. You're also going to want to document the child's explanation of what had happened in your conversation with the child. If you can remember verbatim your questions and the child's answers, that is ideal. Now, you might not be able to do that. It may be a very long visit. They're talking a lot and you don't remember everything. That's okay. You don't have to say verbatim, but if you can, put it in quotation marks, and that just makes it that much more clear. If you cannot remember, then make it clear that you're paraphrasing or summarizing, and try to remain absolutely objective. Remember that whatever you write may eventually go into court. You want to avoid words that carry a lot of judgment or opinions, things like, this horrible injury rather than this injury. So we want to stay very objective. Let's take an example and pull all this together. Meet Samuel. He's a 5-year-old boy, and he comes to your office with difficulty breathing because he's got a history of asthma. So he's basically having an asthma attack. It's fairly mild, but he is kind of working a little bit at breathing. So you say, hey, Samuel, hi, how are you? And you get him up on your exam table, and you pull up his shirt to listen to his lungs, and this is what you see. How would you ask him about these bruises? And I can't see the chat box, so Lori, if you could just tell me what's being written in, but please write into the chat box. What would be a good way to start with this? Would you want to say, hey, Samuel, looks like you've been beaten up pretty badly. Who did this to you? Probably not.
May I ask
Probably
what
not.
happened? May I ask what happened here? Was one suggestion?
Yes. Yeah, you can say, and then since he can't see what you're looking at, you can say, I see some red marks here on your back. Can you tell me anything about those? Yeah. Can you tell me what happened? Can you tell me how you got these marks? How are you feeling? What else happened here? These are great questions. They're very open-ended. What do you remember about this? How did they happen? Yes, and he says, it's a long pause, and he said, I fell. What do you do to follow up? That's a very sort of limited answer to your open-ended question. So you can ask another open-ended question. What would you say?
How did you fall? What did you fall?
How did you fall? Yeah, tell me about the fall. What do you remember about the fall? Yeah. So he says, well, I was on the porch deck and I was on the porch deck and I fell backwards. What would you say now? What did you land on is a really important question, and that's more of a direct question. You're not leading him to say anything. You're not saying you must have fallen on, rocks, didn't you? You're saying, what did you fall on? It's a very direct question. And he says, I fell on the grass. What are you thinking here? Does it seem consistent to you? Does not add up. Somebody asked, did you visit a doctor? Nope, Mommy didn't take me to a doctor. It doesn't match. Why doesn't it match? Yeah, there are no grass mark patterns. The grass is probably not going to give you any specific individual bruises, very specific discrete bruises like this. So the injury pattern does not match. I like that. Tell me about the day you fell. Tell me all about it. Were there any rocks on the grass? Yeah, you can ask about that. Who helped you? That gives you a sense of who was there. That's a good way. So you're asking about this, and they just don't add up. And I share your concern. And my point here is we don't need to ask him questions until he finally breaks down and says, yes, I was beaten. We only need to say to ourselves, I'm concerned about this. These are concerning injuries, and we'll talk about the injuries being concerning in a second. These are concerning injuries. The history doesn't add up. I'm concerned about abuse. I need to take this to the next level and report to the child protection officer. So we don't need to badger him until he tells us what happened. We just need to know something's afoot here. We need to know more information. And even if he didn't tell you anything, you would still be concerned about this. Why? Just looking at the nature of the bruises, what tells you that they would be kind of concerning? The pattern. There may be internal injury. We don't know. We certainly have to be concerned about internal injury. Multiple levels of healing. We don't know that because we can't really tell. Where it is in the body, absolutely. What we've got here is multiple injuries. That's not just one. That's multiple injuries all over, clustered all over the back. Now, remember we said, well, you can fall backwards and you can get something usually along the midline of the back, but that's usually 1 or 2 bruises, not 12. So the sheer number and the location on the torso, which again is generally protected off the midline, is worrisome. And so you would have to, I'm not even sure what accidental mechanism would easily cause this. It would be something pretty unusual. So just looking at them, even if you didn't have an explanation for the child, I would be very concerned. In your examination, what you might want to do is look for other areas of injury. He might have injuries elsewhere. You also might want to look for other possible evidence of a bleeding disorder, that he bruises very, very easily. Now, that does not seem likely to me because these bruises are very small. They're not enormous bruises like you typically see with prolonged bleeding times. But if the child does have a bleeding disorder, then you would expect to see bruises in other places as well. He's also having difficulty breathing. It could be related even if he is asthmatic. Now, that's a good thought. Perhaps he has a rib fracture and it hurts to breathe. That's a very good thought. So how would you describe these injuries? Well, let's start with their location, like they're on the back. Multiple bruising to the torso, posterior aspect of the torso. It looks like, it's hard to see how far off the back we are, at least mid and lower back, right and left and midline. Multiple circular pattern bruises. Let me pull this out. Multiple bruising to the torso, pattern bruises on the back. Yes, so they're bruises. We've got the location, we've got the nature, they're bruises. The color is generally red. Looks like some background brownish discoloration lower down. And what shape are they? They're generally circular, circular to oval. They're clustered. That's a very good description. So you get the sense they're multiple, you might say greater than 10 or something, bruises. Now, you don't have to describe every single bruise there. You can say there's a number of bruises in this area. So that's really good, around 2 centimeters in diameter. That's great, really good. And then how would you document your conversation? Well, you'd want to say, I noticed these bruises, and I asked Samuel, do you remember what happened to your back, or how you got these bruises? And he said, I fell. And then I said, can you tell me more? And he said, that kind of thing is what you'd want to put if you can. Okay, that was fun. That was good. Okay, let's move on to sexual violence. And how might you as a healthcare provider in the school learn about this? And I think there are several ways you can learn about it. One is the disclosure from a child or some other person. One child may tell you about the assault of another child. So that may be the way you hear about it, but it may also be from the child. And again, because your position as a healthcare provider is sort of built on trust, you are more likely, perhaps, to have people disclose to you or ask questions that lead to a disclosure, as we'll see in a minute. You may identify concerns because the child comes to you repeatedly for visits of complaints of pain that's very nonspecific. It doesn't seem to have an organic basis. It's a headache, it's a backache, it's abdominal pain, then it's backache again. So every week or every few days they're coming in with this very nonspecific pain that doesn't seem to have an organic cause, and that may be related to traumatic stress. They may come and ask for STI testing or pregnancy testing, and this would be a big red flag. Or the staff may send a child to you because they're concerned about behavior changes. The child's acting out a lot, the child's sleeping too much in class, or these changes in behavior, so they don't know what to do, and they send the child to the nurse or the doctor who's on site. So let's pull this together in an example. Let's meet Sophia. She's a 14-year-old girl who comes to your office for a headache. Earlier this week, she had a vague back pain. That was on Monday, and this is Thursday. She comes back for a headache. This time, on Monday, she was kind of a little bit withdrawn. Now she's withdrawn and quite anxious. And so you proceed to say, well, tell me something about your headache. How can you describe it for me? And she describes it, and you're talking a little bit about that. And suddenly she says, I need to ask you something. Can you get pregnant by just having sex once? So the question is, there's a 14-year-old with a fairly provocative question. She's anxious. Maybe in your mind you're thinking, she's got some of these behaviors are sort of add up here as something of concern. Besides answering her question, which you're going to answer her question, what else could you say to sort of broach the topic of talking about sex and any concerns you might have related to that? How could you introduce the topic in a non-threatening way? Let's assume you've already built rapport. We don't have to do that. We're just broaching the subject. Yes, that's a good one. Is this question about yourself or a friend? Can I ask why that concerns you? You might want to say, do you have any other questions about that? You might want to, you can say, do you have a boyfriend? You might want to lay the groundwork a little bit and say, you answer the question, yes, you can get pregnant, da-da-da. Sophia, I get a lot of questions from kids about things like this. And so I like to talk to my students about it, talk about sex and sexual activity and pregnancy and things like that. So I'm just curious, you mentioned you had this question. Can you tell me a little bit more about why you had this question? Or do you mind if I ask you some questions about sex and your health, so I can get to know a little bit more about you, if there's something I can do to help or offer you some information. Something like that. Tell me what's on your mind is another one. Somebody wrote in, that's good. Tell me what's on your mind. You could say, Sophia, you seem a little anxious and sort of withdrawn. I'm a little concerned about you. Can you tell me what's going on? Does it have anything to do with this question you were asking? Is there anything you want to talk about? What are some things you would not want to say? Did you have sex? Are you pregnant? Who did you have sex with? Yeah, these are also jumping on the child, assuming a lot, and being very direct right out of the gate. So yes, you're too young to ask these questions. I love that. You're too young. You're legally too young to have sex, right? So all of these things it's very off-putting, potentially traumatizing, and are sort of invasive. So we'd want to take a much more general, much more low-key, open-ended approach, normalizing the whole idea of talking about sex, because, and you have a very good reason to talk about sex, because you're a healthcare provider, and this is an adolescent, and that's what healthcare providers do, is talk to kids about sex. And so they, in a sense, can expect it. Yeah, you don't want to be judgmental of unprotected sex. Absolutely. So finally, so you ask some questions, and it finally comes out that Sophia says, well, I met this guy. He's 19 years old. I met him online, and this happens all the time, incidentally. I met this guy online. And I decided to meet him because he seems like a really, really nice guy, and I have a crush on him. So I decided to meet him, and we went out driving, and I just wanted to go get lunch, but he went to this parking lot and wanted to have sex. I really didn't want to have sex, but he really wanted to, so I sort of had to. I didn't want to, but I had to. And then he took me home after that, and that was on Sunday, and I'm really worried I'm pregnant. There you have it. So, are you concerned about this, by the way? 14-year-old, non-consensual sex with a 19-year-old, absolutely. What are the things you as a healthcare provider need to know? Let's look at this. I think it would be important to clarify the term. Sophia, you said that you had sex. Kids can mean a lot of different things when they say they had sex. So I want to make sure I understand you. Can you tell me specifically what that means? And she'll probably blush. And so you could say, was that, his penis in your vagina? That kind of thing. You give her a little help. And so you can clarify what that means, because we want to make sure that we're on the same plane, on the same page. You also want to know as a healthcare provider if there was any associated bleeding. Was there bleeding afterwards? Was there pain during the episode or afterwards? Often there's dysuria after for a couple of times when the child goes to the bathroom afterwards. Any discharge that they've noticed in the ensuing days. Is there continued bleeding? So you want to know what kind of sexual contact, the extent. If it was penile vaginal, was there anything else? It was also penile oral. When this occurred, and the reason why you need to know when it occurred is for things like HIV prophylaxis must get started within the first 72 hours, pregnancy, emergency contraception within 5 days. So you need to know what kind of sexual contact, when it occurred, associated signs and symptoms, which may tell you there's an injury, there's a pretty severe injury, she's got a lot of bleeding, so we need to get her to the hospital now. And usually kids don't know a lot about this, but if you can elicit any information about the alleged offender to get a sense of whether he was high risk for HIV, and usually we don't get a lot of information on that, but it might be helpful if you can. And whether or not a condom was used, sometimes the child doesn't know, they can't remember, but that will also help give you a sense of the degree of risk and exposure. So you want to know these healthcare things are very important. And again, we're not going to do bang, 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 like a list of questions, but we just sort of say, can you tell me what you remember? And then sort of fill in with some direct questions, going at a very slow pace, very non-judgmental, pausing, so the child doesn't feel like you're interrogating them or the list of questions you're asking. And then you'd want to know, how is the child feeling now? Because you want to know, is that child suicidal? Has that child been hurting herself or thinking about hurting herself? Is she homicidal? Does she want to get back at him? Knowing what her state of mind is really, really important. And knowing about any safety concerns, fears she might have that he might come back and find her, he knows where she lives. Those kinds of things are all important for you to gently ask about. And then, of course, using this trauma-informed approach, you're going to want to be thinking about some of the concepts of trauma-informed care, considering the impact of the trauma on what this child's thinking, her perceptions of herself, of her world, how she's perceiving you and what you're saying are all going to be viewed through this trauma lens. She probably feels very helpless, perhaps very ashamed, very scared. She may think you are an authority figure and be expecting you to be very judgmental and punitive even. So she may have this sort of distorted view. So you have to be thinking about how her trauma may impact her behavior and her perceptions. We need to be extremely respectful and empathic without judgment, just listening much more than speaking. The child may want to tell us what's happening, may or may not, but we don't want to dominate the conversation, but instead be very open with some pauses to allow the child to think. They want to talk, they talk more, they don't. Building the sense of safety and trust. Saying, we've been talking for a few minutes, would you like something to drink? Are you warm enough? Those kinds of things that are addressing basic needs can make the child feel comfortable. Being very transparent about why we're asking questions before we ask all those questions about bleeding, pain, et cetera. Say, I'll need to ask you a few questions now that you've told me about having sex with this boy and what you've just talked to me about. I'm going to need to ask some questions so that I can know whether there's something I can do to help your body feel better or your mind feel better, and to help me come up with some ideas for what might help you, and then we can talk about that. So you're giving an explanation. I need this information so I can make some decisions about what might be of help. And then getting that child's consent. Is it okay if I ask you these questions? You don't need to answer them if you don't want to. Yes, go ahead and ask them. So you're empowering by giving information and getting consent. And focusing on the child's strength. It sounds like you've been through a lot. That's been very hard the last few days. You've been through a lot. You were very courageous in telling me this now. So you're empowering them, making them feel like they have some agency. What can you tell your patient? You may or may not have a lot of information about what happens in your jurisdiction in the area. If there is a sexual assault, it's actually a good thing to figure this out ahead of time, to know what the protocol would be. Perhaps even to visit if you know the child's going to have to go to a community hospital for a forensic medical evaluation, have a visit there and know what they're in for. But you can tell your patient, using the transparency that's so critical to trauma-informed care, you can talk about the reporting process, why it's important. You're not going to want to handle this yourself. You're going to need to take this to the child protection officer, and they're likely going to involve other people outside the school. And this is why I need to do it. You're not asking permission of the child because you know you have to do this, but you're explaining why it's important, that I need to get others to help me to help you. This is more than I can handle. I need to get others to help me. Talk about that process. So that the child has a sense of what's coming down the pike. They're less anxious if they know what's ahead. Talk to them about notifying the parents. The parents are going to be aware of this. How do you want to handle that? Talk about the need for medical evaluation, what this entails, why it's needed. As much detail as you can provide. Information is everything. People will feel much more in control if they have some idea of what is ahead. So what you know, you can explain to them. You might talk about common trauma reactions, of being very depressed, of being angry, of maybe wanting to harm oneself or harm somebody else, explaining trauma reactions that are common so that the child gets some sense that they're normal for having these responses. You want to answer questions. The child may have a lot of questions about her body that you can answer as a healthcare provider. Am I pregnant? Am I ever going to be able to get pregnant now that I've been raped? Those kinds of things. Discussing a support or a safety plan, what the child thinks should happen, what the child wants in terms of support, what they think is best is all important to discuss. If there is a forensic medical evaluation to be done, and there would be in this case, it's been 5 days, they're probably going to want to do a forensic medical evaluation, whether it's done at an embassy or at a private pediatrician or a hospital. It's usually going to involve this type of thing: obtaining information about the assault, assessing the child's overall health and treating anything that's acute, and then documenting injuries that are on the body and especially to the genitalia, and that's usually going to involve a genital exam. Depending on the timing, the jurisdiction, the site, they may or may not obtain a forensic sexual assault evidence kit, and you can explain what that is. They'll conduct a genital exam. They're going to offer some sort of sexually transmitted infection and pregnancy testing, and probably medications and emergency contraception. They may or may not want to do drug testing. These are the typical things that are involved in a forensic medical evaluation. And you need to sort of explain what this involves so that they have some sense of it. And you can be free to say, I don't know a whole lot about this, but I know that they're going to want to do a physical exam and a genital exam and et cetera, et cetera. So the child has some sense. You always need to prepare them as much as you can. Now think about your role in this. And you may have different roles depending on the school you're in, your policy, but think about how you might help. You can bring the trauma-informed approach to wherever the child has to get their medical evaluation. Let's say they have to go to the community hospital, the emergency department. That's where they're going to go because the law says that that's the place where they get their forensic medical evaluation. So you know the child's going to have to go there. And you also know or suspect that probably there's not going to be a lot of trauma-informed care when you get there, that probably providers are not really familiar or comfortable with doing sexual assault exams. They're certainly not comfortable working with somebody from an international school. They may feel very intimidated by that. They may be very gruff. They may be very insensitive. We don't know. So it may be that you can be the liaison between the child and the healthcare provider and bring that trauma-informed approach with you so that you can sort of cushion the child and protect the child from the insensitivity of the environment. I'm not saying that all community hospitals are insensitive and not trauma-informed, but if they are, you can act as a buffer. So you might want to go to the hospital with the child and the family. Before the provider gets started, you might want to say, I'm the school nurse or I'm the school doctor. Can I just talk to you for a few minutes outside about what might be happening, so I get a sense of what to expect and I can prepare Sophia. So then the provider tells you this is what we're going to do. Great. Then you know ahead of time. You can ask what is absolutely mandatory and what is optional. Can the child refuse any of these things? Because you want to know what child's rights are. Are they allowed to say, no, I don't want a forensic evaluation kit? I don't want a forensic evidence kit? Are they allowed to refuse the exam? And so you need to make sure that you make it clear to the child what their choices are. Because in most cases, healthcare providers are not going to individually say, you can decline to have the genital exam, you can decline to have the testing, you can decline to have the medications. They don't usually say things like that. So you need to know and be aware that what the child can and cannot decide and refuse. Provide comfort, soothe their anxiety. That the healthcare provider may be doing the genital exam. You can be there at the head of the bed, providing some explanation of what's happening, being very watchful to make sure the child's not too distressed, notifying the examiner if the child is becoming uncomfortable. You can also find out whether there's a choice in the gender of examiner. Is it possible that the male doctor who you have right now can go get a female doctor to do the exam? So you can ask these questions because the patient, your child, is not going to ask them. The parents are probably too scared to ask anything. So you can be the liaison. You can provide explanations. You can talk to the child while the exam is happening. This is why they're doing this. This is why they want to draw blood. What do you think about this? You can answer the child's questions. You can ask questions to the provider. Now what are you doing? Can you tell me a little bit more about why you want to draw that blood? So that they're sort of forced to give an explanation so the child can hear it. And then you need to emphasize, and you may need to emphasize to the healthcare provider, but certainly to the child and the parents, that if there is no physical finding on the genital exam, that does not mean abuse did not occur. It's a very common notion that if someone was raped, then they're going to have injuries on exam. But the genital areas, we'll see in a minute, heals very, very quickly. And so there may be nothing. At 5 days out, there may be nothing to see. And that does not mean the abuse did not occur. And that's an important point to drive home. The WHO, World Health Organization, has come out with some excellent guidelines on treating children and adolescent victims of sexual violence. Now, I'm not expecting you to take this WHO guidelines with you to the hospital, but just to know there are certain recommendations for treatment. And again, this is going to vary with the country you're in and the sophistication, the resources of the hospital, whether they almost always are going to treat or test for HIV and pregnancy and offer HIV prophylaxis and contraception, emergency contraception. Those are pretty much universal. The rest of things like gonorrhea, chlamydia, trichomonas, they may do presumptive treatment. They may test and wait to see what the results are. They have their own way of doing it. They're recommendations by the WHO. And if the healthcare provider seems a little bit confused and not sure, you might want to suggest looking at the World Health Organization guidelines. Another thing that you can do as an advocate is address some common beliefs and misconceptions that the child may have, the family may have, or even the healthcare provider may have. And one of these is the way a child feels about their body. My body's tarnished. I've had sex. I'm no longer a virgin. My future husband will know this and know that I'm not a virgin. And in some cultures, that is extreme and can be an extremely major catastrophe for the child, for the family. There can be a lot of implications for not being a virgin. And so it's really important to be able to talk to the child about what they mean by being a virgin. What does it mean to them to be a virgin? What does it mean to their family? What does it mean to their community? Does the fact that this was not consensual, does that have any impact on whether or not you're still a virgin? Get a sense of ideas about how the child perceives virginity. It's also important to talk about the fact that in all likelihood, this child's genitals are absolutely normal, and there's no way her husband 10 years from now is going to be able to know whether the child is a virgin or not. There's no such thing as a virginity test. That two-finger test of antiquity is not reliable. So the vast majority of children who are evaluated for sexual abuse have entirely normal exams or nonspecific genital exams. Even children who have injuries tend to heal completely without any residual scarring. And this is just one of many studies that have been done. It's fairly old now, but I still use it in court because it's so well done. Over 2,000 children were referred for possible child sexual abuse, ranging from infancy to 14 years old. 96% of them had entirely normal or nonspecific genital exams. So there was no finding that when they saw, the person could say, oh, that child's been, had sex before. When you examine children within a few hours after an assault, sometimes they have an injury, but as I mentioned, in the vast majority of cases, the injury heals completely within a few days to a few weeks, and then any subsequent exams are not going to show anything that would suggest that there's been prior trauma. So in some cases, there may be evidence of old injury, but in most cases, there's not. So in all likelihood, as far as her body is concerned, you can say your body is the same as it was before you had sex. Another thing that kids are concerned about, if this were a boy and a boy was raped, sexually assaulted by a man, the boy might say to himself, I'm a boy, I was raped by a man, that must mean I'm a homosexual. It's really important to talk to kids about what they think, what they're thinking, what their fears might be, what their concerns are about what's happened, because this is when they're going to talk to you about virginity or homosexuality. And it's really important, if a child does bring this up, is to say to the boy, most boys who are sexually assaulted are heterosexual. And there is no evidence that sexual assault causes a change in sexual orientation. It's not going to make you a homosexual. And finally, you can talk about how sexual assault is a crime involving power, not sexual urges. This is a crime of power and control, not sexual desire. So I think that's really important to address these issues. Some children who come to me are really concerned. They ask themselves, well, why me? Why was I assaulted? What does that mean about me? Do you have any concerns like that? And that sort of opens the door so the child can talk about that. And then finally, this is all my fault. It's very, very common for children of any age to feel that the sexual assault was somehow their fault. So it's really important to talk about that, talk openly about that, find out what they mean about that, open-ended questions. You say, this is all your fault. Can you tell me what you mean by that? Why is it your fault? And then you might you don't want to say, you're wrong. You don't want to invalidate their feelings. But you might want to say, you know, I understand that you feel this is your fault. I understand that, and thank you for explaining that. What you've told me, you know, I have a slightly different perception of that. Do you want to hear what I think about that? You're giving them control. Would you like to hear my perceptions? Yes or no? Yes. And then you can go on to say, you know, the way I see it is that no one deserves to have what happened to you. No one deserves to have what happened to you happen to them. And that the only person who is responsible for what happened is the person who assaulted you, and that's this boy, this man. He was responsible for his own behavior. You're not responsible for his behavior. That's in my view. So you're saying this is another way of looking at it. And that sort of helps them to identify another way of viewing the situation. So you're saying, I understand why you think it's your fault, but there is another way to look at it. So in conclusion, I think you as school health personnel have a very important role in child protection from your unique background as a healthcare provider. Your role confers a certain amount of respect and trust that patients, students will give you, and that it sort of allows you to be a vehicle for them to talk to you about their concerns. Unique knowledge of your community and national response to sexual violence is really critical, because the more you know about what is the process to responding to sexual assault or serious physical injury, the more you can educate the parents and your child about what's going to happen, and it helps them through that. You can act as an effective liaison, but only if you yourself have some knowledge. And you can, because of your trauma-informed approach and your ability to sort of insert yourself as a trauma-informed representative of the child, you can prevent secondary harm from medical intervention, which I think is really incredibly important, because once a child discloses abuse, there's the potential for a lot of secondary harm associated with intervention and investigation. So just to close, this is the Global Child Protection Webinar Series slide again, and I'm going to stop sharing, and I think I have this is my contact information. We're going to take questions now, but also I would hope that if you have any other questions, you'd feel free to reach out to me. And also let me know if you're interested in learning more about this. There's so much more we could talk about, either in future webinars or perhaps in discussion groups that we have. There are a number of people who want to talk about issues. Perhaps we could have a discussion group. I'm opening it back up to everybody and stop sharing. Lori, would you